Start with the first slide.
Sir, this presentation mode nahi hai.
You have shared the PowerPoint or screen?
Screen.
Okay, share the PowerPoint. Stop sharing.
अभी भी इसमें नहीं आ रहा है.
नहीं या ठीक है, अभी ये कर दो.
Right.
From beginning.
Yeah.
Visible?
Yeah, now clear. Yeah, you can start now.
So, good morning all. Today I will be presenting a topic called pachychoroid spectrum. So, the term pachychoroid refers to a newly described phenotype in which functional and structural choroidal changes are thought to play a key pathogenic role in the spectrum of related retinal disorders. There is a lack of a consensus on various phenotypes, which can lead to these disorders being categorized together with neovascular AMD. In order to avoid such miscategorization, and understanding of how the choroid is involved within the spectrum and a better knowledge of most relevant clinical signs of the pachychoroid phenotype are important, which we are going to discuss in this presentation. So definition, there are two types. One is uncomplicated and complicated or pathological pachychoroid. In uncomplicated pachychoroid, it is seen in eyes with choroidal hyperpermeability with focal or diffuse congestion or an increase in choroidal thickness and dilated choroidal vessels, which are known as pachyvessels, and there is reduced overlying choriocapillaries, but without pathological findings such as subretinal fluid, CNVM, or RPE atrophy. So the normal choriocapillaries are reduced in size, but there is development of new choroidal vessels, which are known as pachyvessels. And complicated or pathological pachychoroid is the presence of all the above choroidal features plus pathological findings like subretinal fluid, CNV, and RPE atrophy. Choroidal hyperpermeability is the chief etiology. It is greater in incidence in complicated than in uncomplicated pachychoroid. So common pathophysiology is choroidal thickness per se is not the most important criterion. This is to be remembered for defining the pachychoroid disease phenotype, because there is no universal cutoff value for the choroid, how much thickness it is. There is no universal cutoff value, and moreover the choroidal thickness may vary depending upon the duration or chronicity of the disease. So as the disease progresses, initially the choroid can be thick, but it can thin out as the disease progresses. There is no specific fixed value. The presence of dilated or congested vessels in the choroid and not thickened choroid per se is the most salient feature. So pachyvessels are thought to result in focal or diffuse increased choroidal thickening with overlying choriocapillaries and Sattler's layers thinning. So choriocapillary and inner choroidal layer, that is Sattler layer, and choriocapillaries are thinned out, and pachyvessels show along with diffuse choroidal thickening is seen. Along with this, there is an inward displacement of the pachyvessels and the reduced thickness and decreased flow in the choriocapillaries, which leads to disruption of the RPE and Brooks membrane due to ischemia and or chronic trauma caused by increased choroidal pulsation or mechanical stress. Eyes with pachychoroid but without exudation, CNV or RPE atrophy, that is uncomplicated pachychoroid, have choroidal hyperpermeability, focal or diffuse congestion, or an increase in choroidal thickness in pachyvessels. There is variable resistance of the RPE to the fluid or hydrostatic pressure imbalance, and different degrees of ischemia and inflammation is seen with consequent development of choroidal neovascularization. Now, various quantitative features are congestion as manifested by thickening on the OCT. Normative value of choroidal thickness is influenced by multiple factors like age, axial length, blood pressure, making it difficult to define what is normal. Previously, the cutoff value considered was more than 300 microns subfoveal thickness, but there is no universally accepted threshold. Choroidal thickness measurements in eyes in pachychoroid disease are comparable between spectral domain and swept source OCT. However, swept source OCT may be more suitable in eyes with choroidal thickness more than 400 microns and subfoveal active lesions, especially in the presence of large stromal area in the inner choroid related to inflammation and edema. Second quantitative feature is choroidal hyperpermeability. Using ICGA to image the disorders, it can be seen that pachychoroid spectrum can reveal delayed choroidal filling, choroidal venous dilatation, and hyperfluorescence. Exact mechanism remains uncertain, but underlying one hypothesis is that functional consequence of choroidal ischemia results in congestion and stasis of the choroidal lobule. Third quantitative features is blood flow signal attenuation within the choriocapillaries and inner choroid with OCT angiography. This can be correlated with localized choroidal thickening attributed to dilatation of the outer Holler's layers vessels and thinning of choriocapillaries and Sattler's layers. And there is higher prevalence of the inner choroidal flow signal attenuation zones in pachychoroid eyes than in normal controls. Qualitative features: pachy vessels or dilated choroidal vessels in the Holler's layer. As we know, the choroid is divided into three parts: the outer Holler's layer, middle Sattler's layer, and the choriocapillaries. So in the outer Holler's layer, we can see the dilated choroidal vessels. The pachy vessels or hypertrophic vascular entities are thought to result in focal or diffuse increased choroidal thickening and overlying choriocapillaries with Sattler's layer thinning and asymmetry. Second qualitative feature is RP layer alteration and thinning of the outer nuclear layer associated with ICG. Yes, sir.
Amok, in the previous slide, can you point out where exactly we have to look for these?
Sir, these are the outer Holler's layer. This is the Holler's layer. This is the Sattler's layer which is thinned out. And here there are pachy vessels just underneath the Brooks membrane.
So they are dilated and they have come just under the
Yes, and there is a slight inward displacement which is seen here. At the yellow arrow which is seen, there is a inward bulge.
Okay.
So
Okay.
that inward bulge is important. So RP layer alterations and thinning of outer nuclear layer. There are foci of choroidal thickening over the pachy vessels directly external to the RP Brooks membrane complex. Focal attenuation of the choriocapillaries and Sattler's layers overlying the pachy vessels brings them closer to the Brooks RP complex. Inward displacement of these congestive pachy vessels and atrophy of the choriocapillaries may lead to disruption of the RP Brooks membrane due to ischemia and or chronic trauma. And they are seen as dilated arterial filling of the choroid on the FA and ICG, or as blood flow signal attenuation within the choriocapillaries and inner choroid on the octa. Second is RP layer alterations and thinning of the outer nuclear layer. A thinner outer nuclear layer related to focal ischemia of the choriocapillaries linked to RP disruption and photoreceptor apoptosis is seen. There is choroidal neovascularization. The postulated mechanism which can predispose to both type 1 or type 2 neovascularization is relative ischemia with the choriocapillaries and choriocapillary attenuation and or chronic mechanical disruption of the Brooks membrane. So this is the patient of CSCR. Here we can see the altered foveal reflex over here with pachychoroid. And in ICG, we can see mid-phase ICG hyperfluorescence. Then the next qualitative feature is pachychoroid. So pachychoroid is a subtype of drusen that is usually associated with increased choroidal thickness, choroidal hyperpermeability, and underlying pachy vessels. The drusens are found in the context of surrounding pigmentary changes and distributed throughout the posterior pole. Typically, they are more than 125 micron in diameter. So this diameter is compared to the diameter of the vessels which come out from the optic disc. So in comparison with that, this measurement is done. So pachychoroid typically more than 125 microns. Either they are associated in isolation or in groups of only a few yellow-white deposits with well-defined outer borders. They have well-defined outer borders, or the outer border can also be smooth, convex, or jagged. Then the clinical spectrum of disorders, it can be divided into three subtypes: those with exudative changes, those with developed neovascularization, and those with atrophic changes. So pachychoroid constitutes a common pathogenic process, and within the clinical spectrum, overlapping features and progression from one disorder to another are frequently observed. There is no distinct entity; they are all one common pathogenic process in this spectrum. So the first comes disorders with exudative changes. Number one is focal choroidal excavation. In this, there is idiopathic localized concavity in the choroid occurring without any posterior staphyloма, trauma, or scleral ectasia. Pachychoroid features in eyes with FC include hyperfluorescence and localized choriocapillary thinning on ICGA. Fundus examination appears normal or can show non-specific pigmentary changes like indistinct yellowish white spots. And FCE can be divided into two patterns based on spectral domain OCT findings. It can be either non-conforming or confirming. Non-conforming is that photoreceptor tips are separated from the RP, and confirming there is no separation between the photoreceptors and RP. So this is the picture of focal choroidal excavation. The ICG shows hyperfluorescence with localized choriocapillary thinning, and OCT shows localized concavity in the choroid. Just underneath the neurosensory detachment, we can see a localized excavation in the choroid. Then the second type is central serous chorioretinopathy.
So
Here we can see
just the previous to this slide.
Yes, sir.
So here there is an excavation.
Yes.
Okay, so usually, as you said, in pachy vessel there should be bulging.
Yes,
of
sir.
the, so there should, like, the outer layer should be thinned out and there should be bulging. So why here there is a excavation? Hello.
Sir, thinning of the RP Brooks membrane
Okay.
along with
Okay. Show the next slide.
the CSCR, there is serious detachment of neurosensory retina with underlying serous PED. It is believed that choroidal congestion and choroidal hyperpermeability manifests as increased choroidal thickness and dilated choroidal vessels on OCT play a contributing role, enhanced depth OCT, playing a contributing role in serous PED and lead to focal defects of the RP with SRF most commonly located in the macular region. The chronic presence of SRF ultimately damages the RP, although in some cases there can be underlying multifocal choroidal vascular dysfunction and can affect the RP without the presence of subretinal fluid. So SRF may not be there also in CSR, some CSR cases. So on FFA, we can see the smokestack or mushroom cloud pattern of hyperfluorescence. This is a less common pattern. More common is ink blot. So smokestack is seen in 10 to 15% of the cases due to increased protein concentration in the leaking fluid. ICG, there is delayed choroidal filling in the early phase with hypofluorescent areas resulting from non-perfusion of choriocapillaries. And in OCT, elongation of photoreceptor outer segments, granularity in the subretinal space, and pigment epithelial detachment at the leak site is seen. Then there is a third entity is the peripapillary pachychoroid syndrome, which is associated with the IRF and or SRF extending from the temporal disc margin into the macula or in the nasal side of the disc in the absence of any neovascularization. It shares common features with chronic CSCR, such as RP alterations, similar in ICG findings. In some cases, there is presence of serous pigment epithelial detachment, gravitational tracts, evidence of retinal detachment outside the peripapillary region with fundus autofluorescence, and outer retinal atrophy. However, choroidal thickness profile is significantly different. This is point to be noted from typical CSCR, in which there is nasal macular choroid can be thicker and the thickness sharply decreases towards the temporal side. And additionally, in peripapillary pachychoroid syndrome, there is presence of choroidal folds. The age group is older as compared to CSCR. There is a smaller cup to disc ratio and mild disc leakage on late FFA. These are the common additional features. So ICGA shows delay in the choroidal filling in the early phase with hyperfluorescent areas resulting from non-perfusion of choriocapillaries. FA shows the late disc leakage, which is seen in the lower left photograph. And OCT shows intraretinal fluid, focal neurosensory detachment, and focal PED. Disorders with neovascularization. This is the second component of the pachychoroid spectrum. We discussed the first, now with neovascularization. So pachychoroid neovasculopathy. In pachychoroid neovasculopathy, patients with, there is no evidence of neovascular AMD, that is without any drusen or only hard drusen are seen. Myopic degeneration or other causes of degeneration develop type 1 neovascular tissue overlying the focal areas of choroidal thickening and ICGA hyperfluorescence. The second entity is polypoidal choroidal vasculopathy, PCV, also known as, by some investigators as aneurysmal type of the type 1 neovascularization, sub-RP neovascularization, but of aneurysmal type. It was first described by Annuzzi et al. In 1990. It presents clinically as subretinal pigment RPE and or subretinal hemorrhage with fluid accumulation, similar to exudative AMD. PCV can be considered as a variant of type 1 neovascularization with vascular dilatations and feeding vascular network underneath the RPE. However, the point to be noted that in recent studies on enhanced depth OCT and swept spores OCT demonstrates that patients with PCV or aneurysmal type 1 neovascularization frequently have thicker choroids. This in contrast to the choroidal thinning observed in the typical neovascular AMD. So this point is to be noted and it's a differentiating feature. So in PCV, ICGA, FFA, and OCTA show vascular dilatations and feeding vascular network underneath the RP. And on OCT, we can see a PED with type 1 CNVM with vascular dilatations. So this is a class. This is to be remembered, especially for the DNB students. In 2012, the Everest study, which was proposed several diagnostic criteria based on ICG imaging for PCV. So according to that, PCV was diagnosed based on early subretinal ICGA hyperfluorescence, which appears within first 5 minutes of ICG dye injection. And along with this, there should be at least one of the following diagnostic criteria. either nodular appearance of polypoidal lesions on the stereoscopic viewing, or there can be hypofluorescent halo around the nodule on ICG, or abnormal vascular channels supplying the channel or channels supplying the polypoidal lesion, pulsatile filling of the polypoidal lesion, or orange subretinal nodules corresponding to the hyperfluorescent area, and massive submacular hemorrhage. So if the first one and any of the next 6 is present, then it is considered to be BCV. Then the third category is disorders with atrophic changes. So here there is pachychoroid pigment epitheliopathy. It was first described by Varro as involving the presence of choroidal congestion and choroidal hyperpermeability. It manifests as increased choroidal thickness and pachyvessels, leading to drusen-node RPE changes and or small PEDs in patients without serous macular detachment, typical of classic CSCR. So there is no serous macular detachment, but there are drusen-node RPE changes and or small PEDs. These PEDs can be found directly overlying the localized areas of thickened choroid or choroidal vessels, and there can also be sub-RP neovascularization with or without polypoidal structures and RP choroidal atrophy. So this is a red-free image showing the pachydrusen, and on OCT we can see increased choroidal thickness and pachy vessels with drusenoid RP changes and some small PEDs, but there is no serous macular detachment. So now coming to the management of exudative changes, of neovascular changes, it is either anti-VEGF and or vorteporfin PDT. So this is the basic, but there are many studies which need to be noted, especially by the DNB students. The Everest study assesses the effect of vorteporfin PDT combined with intravitreal ranibizumab, or vorteporfin PDT alone versus intravitreal ranibizumab monotherapy in patients with symptomatic macular PCV, and the conclusion was that VPDT combined with IVR or VPDT alone was superior to IVR monotherapy in achieving complete regression of polyps. Of course, PDT is no longer available. The second is Everest 2 study comparing IVR monotherapy with IVR plus adjunctive VPDT administered at baseline. So conclusion was combining the two achieved on an average significantly greater BCVA gains than IVR monotherapy. So Everest 2, the main difference was that both were combined at the baseline and not subsequently after 3 months. Then Fuji Science study elucidated whether VPDT should be administered at the beginning of treatment or during follow-up of IVR therapy. And the conclusion was that initial VPDT combination led to a significantly fewer additional treatments despite similar visual and anatomical benefits at 12 months in both groups. So if you combine before or after, even though the visual and anatomical benefits are similar, if you combine it initially, VPDT at the starting, then it leads to significantly fewer additional injections of IVR required. Then the fourth study is laptop study, which considered the primary outcome of the proportion of patients gaining or losing more than 0.2 logMAR units from baseline till 5 years follow-up in VPDT versus IVR. And the conclusion was gain in visual acuity seen was 17% versus 30% in VPDT versus IVR groups in first 2 years, which was written at 5 years. So intravitreal ranibizumab monotherapy was more significantly successful. And the last study is Planet study, which evaluates the efficacy, safety, and tolerability of intravitreal aflibercept monotherapy versus IV aflibercept intravitreal plus VPDT in the treatment of PCV. Conclusion was that results at week 96 showed that IAI monotherapy was non-inferior to IAI plus VPDT. That means you can just give aflibercept instead of combining it. And the proportion of patients with complete polyp regression was also better in the monotherapy. Then lastly comes management options for exudative causes, in which there is absent neovascularization. Here we are basically discussing CSCR without neovascularization. So traditionally, treatment of choice was focal continuous wave thermal laser treatment with argon or diode laser. Thermal laser can reduce the duration of subretinal fluid, but the final BCVA does not differ significantly compared to no treatment, and its use should be limited to extrafoveal leakage size only. The other therapies are transpupillary thermotherapy with 810 nanometer pulse diode laser with a duration of 30 to 40 milliseconds, or subthreshold micropulse laser, or antagonists of mineralocorticoid receptors and glucocorticoid receptors like spironolactone and eplerenone. And finally, the PLACE study, which was conducted, half-dose photodynamic therapy versus high-density subthreshold micropulse laser treatment in patients with chronic CSCR, which shows superiority in terms of complete resolution of subretinal fluid and functional improvement in half-dose VPDT versus half-density subthreshold micropulse laser. So this concludes my presentation. This is my bibliography.
Yeah, so pachychoroid is a very complex spectrum. And what are then the treatment options, and how do you clinically suspect that this patient might be having pachychoroid?
So on enhanced depth OCT, we have to look for the dilatations in the outer choroidal layer.
Any signs on clinical examination first?
Clinical examination in in PCV, we can see subretinal hemorrhage, lipid exudation. That should be considered.
Any particular age group for presentation with pachychoroid?
Sir, in middle-aged group, it will be seen because it is spectrum is similar to neovascular AMD. So generally, more than 55 to 60 years age, it can be seen, not in young.
Okay, so generally ARMD is seen in even older age group.
Yes, sir.
And drusen, the typical drusen which we find in ARMD, are they also seen with pachychoroid?
I have not read that, sir. So here is the drusen are in pachydrusen are associated with the choroidal thickening. Neovascular AMD, generally there is no choroidal thickening associated.
It's opposite, right?
Yeah, if both are present, then it marks more towards pachychoroid spectrum.
Okay, can you show one OCT image where you can clearly see the dilatation of the choroidal vessel versus a normal choroidal vessel?
So in this, actually here it is visible. In outer choroid, we can see the dilatations. So this is the only one I have.
Normal case, normal, where there is no dilatation?
Normal, I don't have in this slide, sir. Here it can be concerning here to PCV. Normal, I don't have OCT, sir.
Yeah, let me check and I will show you the. The first most important thing whenever you see any patient is the clinical suspicion. You don't do OCT in all patients, right?
Yes, sir.
So first you have to understand if clinically you are suspicious of pachychoroid. So what are the signs of pachychoroid clinically?
Sir, patient will present with metamorphopsia, first of all. Then we can see, if we see drusen, then automatically we'll go in ahead for a OCT scan. And the choroidal thickness, we cannot judge clinically, basically, but only on OCT we can look for. If any suspicion, then we can order for enhanced depth OCT.
Correct. So
and
first,
subretinal heme and macular exudation, if it is there.
Yeah. So any metamorphopsia, decrease of vision recently, or other eye having lesions or scar, and even IPCV, the polypoidal ones, they will present with subretinal hemorrhages also.
Yes.
And any case of choroidal neovascular membrane, which is not associated with signs of age-related macular degeneration. So now here you can see the normal vessels and the abnormal vessels. Can you see?
Yes, sir.
So up to, as you said, 300 micron, but not strictly, but you can see that up to 300 microns, this Heller layer is ending here. While in case of pachy vessels, you can see it is even larger than that. So this is enhanced depth imaging, which is seen in SDOCT, but you can see better with the swept source OCT. And you can measure these vessels. So now onwards, in a normal case also, you try to measure the vessels, choroidal vessels, and you will understand when it is more than what is usually there, right?
Yes.
Okay, good. Any other questions from other fellows? You can. Okay, then we'll end the meeting now. Okay.
Yes.
And I think PDT, the role has now quite reduced. Also, lack of
Yes, sir. That,
availability also.
yes.
And
Vorteporfin is no more manufactured.
and also the monotherapy with various anti-VEGFs have shown better results, I think.
Yes, sir.
Any particular this thing like anti-VEGF which is preferred in case of pachychoroid?
No such studies, sir, comparing the various anti-VEGFs.
Okay. Newer drugs like Paginex are also being used,
Yes.
and aflibercept also used. Aflibercept has a advantage that when you give it on after the first loading dose, you can increase the duration between the two injections. So that is the advantage of aflibercept when we use.
Sir, in a treatment naive eye, we'll first start with 3 monthly doses and then extend
Yeah,
the duration.
the next end, yes. Okay, chalo, thank you.
Thank you, sir.